Hello and good afternoon. I'm Malabika Ghosh. I work as an occupational therapist based at the motor neuron disease team at the Royal Preston Hospital in Preston, UK. My role within the team encompasses a research and clinical role. OT input within the team has translated into a funded research project based on which this talk is based on that funded project. Today I'm going to talk to you about recognizing the role of occupational therapy in making sense of decision making in motor neuron disease. Now, as we know, the word motor neuron disease is almost like a misnomer because there is no recognition of the global pathology affecting cognition and behavior. Even 10 years ago, we didn't realize, as much as we do now, that cognitive impairment is part and parcel of motor neuron disease. But recently, research literature tells us that almost 50% of our patients have cognitive impairment. We still haven't named and framed it, but it is very much present. Cognitive impairment can have, Cognitive impairment can have a major impact on day-to-day living. For example, in the ability to communicate, in the ability to manage socially, and in their executive functioning, so the ability to make decisions. It also has a profound effect on caregiving because patients can sometimes make inconsistent choices and the caregiver has to bear the brunt of it all. Cognitive impairment can influence the uptake of therapeutic advice from professionals because often the advice that we give is taken up or not taken up depending on how they rationalize things. Cognitive impairment also has economic implications with regards to the allocation and timing of limited resources. And we know in today's world that resources are limited, so we need to target it to the right audience and to target it in a timely fashion. Before I proceed further, I know we have a global audience today, so I just want to give you a little bit of a background about the care of motor neuron disease patient in the UK. The healthcare system in the UK is, the National Health Service, and patients of all ages, of all diagnoses across the country can access the National Health Service, which is free at the point of access. Guidelines that give us a benchmark about clinical practice, they are the drivers. They help us to guide and help us to tailor our clinical practice, and they are national guidelines such as the NICE guidelines. We have regional care centers for looking after patients diagnosed with motor neuron disease, and one such care center based in Preston is where we are based and where this study comes from. The care input for motor neuron disease at our center is very much multidisciplinary in nature, and at any one time we have 130 patients on our record, on our caseload, and we have about 50 new patients diagnosed every year. When we analyzed our practice in the team, we realized that there were some gaps, or there were some areas where needs were not being fully met. Day-to-day clinical practice demonstrated that there were subtle, undefined problems in terms of behavioral changes that the patients and carers were noticing, but we weren't really asking enough questions around them or managing them. When we looked at literature, we realized that there was a gap in evidence in the cognitive functioning domain in motor neuron disease. And when we spoke to our patients and carers, we realized that their health and well-being needs were largely met, but not fully met. So we decided to do a patient and public consultation group, not one, but few, and we gave our patients and carers some questionnaires to fill that helped us understand where our gaps were, where we could input in a more efficient manner. And we realized that there were 3 areas that were particularly shouting out that we needed to look at, more from an occupational therapy perspective. There were 3 areas. One was that their cognitive executive functioning, there were subtle behaviors that they couldn't explain, or the carers couldn't manage. The carers were almost left to deal with a lot of the problems that happened at home, and there wasn't enough professional support for these problems. And we weren't giving the carers and the patients much support with regards to making sense of some of these subtle and insidious behavioral problems that they were facing. When we realized that these were the areas where we needed to concentrate on, it helped us to design a study to address the health and well-being needs of our patient as well as our carer. And the aim was to see how we could empower our patient, how we could improve their locus of control, and just to define what they were experiencing. We designed a mixed method study, and we recruited patients. Till date, we've recruited 20 patients into our study, and any patient who had comorbidities such as dementia or concomitant Parkinson's disease were excluded from the study because of the impact that can have on cognition. We tried looking at a variety of tools, and picking up the right tools was really difficult because the tools had to be sensitive to the motor and the cognitive limitations, the language ability, the fatigue factor, the ability of the patient to engage in the assessment process, and a lot of other things. Our aim during study design was to ensure that we were trying to be as proactive as possible, and we were trying to see patients as early as we can. Because as we all know, a lot of the signs of motor neuron disease can actually set in insidiously a while before they actually get diagnosed. So by the time they get diagnosed, a lot of problems are set in, and further down the line they can get established. We administered a variety of tools to look and explore the patient's cognitive executive functioning. We used Susan Woolley's cognitive questionnaire. We asked the carers to fill up a questionnaire with regards to their perception of the behavior and functioning of the patients at home post-diagnosis. And we also conducted semi-structured interviews with the patients and their carers to explore what their understanding was with regards to the advice that was provided by professionals, and what was their compliance with regards to this professional advice. The study is still ongoing, but what we've realized till date is that memory, attention, and executive functioning are major areas of impairment in the patient population that we've looked at. And characters out of executive functioning that were described were, patients were behaving completely out of character. So the wife would say, my husband was normally a very calm man, but he's become very rude and very abrupt, and I just don't understand how to deal with it. There was a patient who said, I have been a high-ranking computer professional for all my life, and when I meet up with friends now, I find myself suddenly bursting into tears or suddenly bursting into laughter, and it's really inappropriate and embarrassing, and I just don't know why. Some patients described impulsivity. For example, a patient's wife said to us that my husband's going up the stairs every 15 minutes to check on the cat, knowing fully well that the cat's fine, but in the process he's completely exhausting himself and is completely fatigued for the rest of the day, but he still couldn't stop the urge of doing it. There was a lot of mental inflexibility, so patients would refuse to have a wheelchair, although every time they started to get up, they were falling. And, they were at high risk of having a hip fracture or breaking any other bone of the body, but, as soon as they saw a wheelchair, that was a no-go. And some of our carers said that, the patient just doesn't care. It doesn't matter to him what's going on in the family or at home or even to himself. And to the common eye, these symptoms might often seem to be symptoms of depression, symptoms of grief, as the patient still trying to come to terms with their diagnosis. A lot of it is put down to just the circumstances, just the stress. But if we go looking for them, we find that there's more to it than meets the eye. A significant proportion of our patients demonstrated these problems. And I would like to add here that no matter what tool we used, we found that the skill of the therapist was crucial in picking up these problems, because a comment here and an expression there and a behavior there can make a lot of difference. And yes, in research, we know that that can introduce a degree of bias, but these are subjective things, and this is a mixed method study, so we thought everything we include will make sense towards the ultimate goal. Now, before we embarked on this study, the role of the occupational therapist in the motor neuron disease team was geared towards, rehabilitation and a palliative dovetailed management. And our main focus was enabling function. We wanted to enhance the well-being of our patients, and we felt that enhancing well-being would take away some of the negative side effects of the condition. We used a number of strategies like neuro-linguistic programming. I know my previous speakers have talked about mindfulness, a really powerful tool. We at Preston used a combination of cognitive behavioral strategies to help with fatigue management, lifestyle issues, locus of control issues, and we used respiratory management with regards to postural supports, breathing exercises, worked alongside other multidisciplinary team members with regards to adaptations, used a variety of orthoses. As you can see, a few examples and pictures on the screen in front of you. Used them not just to support function, but to position, to help with respiration, to help with prevention of deformities. But we realized by doing this research that it is important for occupational therapists to have equal emphasis placed on not just the physical side of things, but also the cognitive side of things. And it is important to get in there quickly and to be proactive rather than reactive. A lot of our patients would latch on to the idea of a particular diet, or a particular exercise regime, or a particular medication. They would go on the internet, look for lots of advice, because in their minds that is almost a curative fix for the disease, or something that will help them feel better. But if we can support them and we can support the carers in other ways, then I think the locus of control, the feeling of being in control and to do something about this, would be enhanced. To summarize, I'd like to say that patients with motor neuron disease with cognitive impairment are less compliant with their interventions. This is proven, and our research supports that. And patients who exhibit such behavior are not always fully aware, and they have absolutely no rationale for why they're doing it, but they still do it. Our study emphasizes the need for intervention at the point of diagnosis and the importance of being proactive rather than reactive. And we feel that the contribution of occupational therapy in the multidisciplinary team setting is important to manage problems with regards to decision making with the holistic approach, because when we make patients aware of the problems, aware of the cognitive and executive limitations, then that brings it to their awareness, and then we can make decisions regarding, for example, a PEG, for example, a priority of care document, preferred priorities of care document, much more proactively than leaving it till the end when there is irreversible damage done to their system and then there is not much time. We hope that through this study, we would be able to define a pathway to help manage cognitive problems that affect decision-making in motor neuron disease in a much better and efficient manner. These are my references, and thank you.
Thanks, Malabika.
Thank you.
Questions? D.
Thanks very much. And as being the home for Dr. Woolley, who's right back in the back of the room here, I was a little bit confused about the premise, and clarify for me, I'm sorry. You advocate keeping an eye out for cognitive dysfunction early on, but do you advocate testing as a baseline, using this COG screen for literally everyone who walks through the door? Or do you wait till you see observed, obvious COG impairment before you administer to confirm what your diagnosis is?
There's two strands to that question. I'd like to answer the strands separately. Before we embarked on this study, we did not use Dr. Woolley's questionnaire. It was during the study design phase of the study that we realized that there was a questionnaire that was, designed for our patient cohort, and that's when we started using Dr. Woolley's questionnaire, and we use it quite regularly for the study. However, under normal circumstances, as part of the occupational therapy input, we would normally always have a cognitive screen for all our patients, because we feel by the time things become obvious, it is often quite late. And that's why, as part of the preliminary cognitive occupational therapy screening, cognitive assessment is paramount, is important. Now, when the patient presents to us, that can be at different stages of the disease process, and the diagnosis can also be at different stages of the disease process. So sometimes we may not have the time, or the patient might not have the energy to go through a complete standardized assessment system, in which case we would, being an experienced therapist, we would often use a combination of behavioral observations, or we would use a quick assessment of, say, attention, memory, things we know are generally impacted, and then maybe bring them back in clinic at a later point of time when they're fresh and we do a proper testing. But we would always do a cognitive testing, because I think that's key. That's key to a lot of things we do. As a baseline, yes. Yes, definitely. Thank you.
Hi, Kelly Saunders, Barts Health, London. Really, really interesting, really good, thank you. I wanted to ask you about when you were looking at the cognition, did you look at psychological aspects as well in your assessment? Because you spoke about grief and things like that, but obviously we know that psychological factors like stress, anxiety, mood, etc., do impact on your cognitive capacity.
Mm-hmm.
We all see it daily in our own lives if we're running around as well.
Mm-hmm.
And so I just wanted to ask whether or not whether you looked at that at all to see whether it was a pure cognitive deficit or impairment, or whether there was potentially a psychological contribution to it.
Mm-hmm. As part of the multidisciplinary team input with regards to our patients, we would do. We have a wonderful multidisciplinary team. In fact, I've got Pauline Callagher, my center coordinator, with me today, and she would support me in saying this. When we have patients with motor neuron disease, we do, as a team, we would do a variety of baseline assessments that includes quality of life, mood screening, and other screenings. However, when we haven't gone out of the way and done a specific psychological assessment, because conditions, what we have found in our study is cognitive problems have been creeping up even before the patient has been diagnosed, and at that time they didn't have the diagnosis to grieve about or be worried about or stressed about. And yes, further on from the study, it might be useful to look at what are the areas that are causing these cognitive problems. It could be stress, because we know attention is impacted when people are in stressful situations, and more so when they have a long-term condition. But we haven't looked at core psychological components for this study, but that is definitely in the offing, because we want to do, this is a feasibility study, and we would want to do a bigger size study in the future, so that will be in the offing. Exactly. In fact, they all have anxiety. Yeah, they all have anxiety. They all have underlying stress. But yes, how much they contribute to this will require a completely different strand of assessment.
Any other questions? Down the front.
Thank you so much for an excellent presentation.
Thank you.
Sorry to ask yet another question.
No, you're fine.
I'm just thinking about how you break bad cognition. And I'm thinking it's one of the hardest things to do. I imagine you do it over time and gently, but I know, and I certainly, I know with my patients as a general practitioner, one of their fears really was that they were dementing.
Yeah, yeah,
So I think that patients will know something is wrong.
yeah. Well,
I don't know if that's your experience.
No,
and
it is
how do you manage that?
Yeah, to be honest, it's a very, very valid question, because I think when we are in the acute hospital setting, things like this often get thrown to the back burner, but they shouldn't. And it's a very valid point. But in my experience, I found that when we broach this subject to them, it often comes as a relief to many. Not some, but often comes as a relief to many. However, there are the odd examples when it comes as a surprise to some, but we know when they have absolutely no idea, because we found that a lot of our carers had absolutely no idea that patients had cognitive impairment, and it comes as a surprise to them. So we've got to be gently with them. And like one of my speakers said earlier on, I think it was an excellent presentation on how to break the news to children. We would follow some of the same ethos. We would be there. The channels of communication would always be open. And I know sooner or later they will come back to me once I brought it into their awareness that such a thing can happen. You may not see it now, but if it ever happens, come back to me. I'm only at the end of the phone. I will support you through the process. And we had a recent example when a patient was impulsively going on buying things like, they had a community occupational therapy assessment and they refused a stair lift thinking they're fine. And then 1 week later, tried to go up the stairs, had a panic attack, and decided to spend £10,000 on a bespoke stair lift. And when I heard the news, my first thing was, there is something we need to address here. However, for the patient, that was completely normal, because he saw it as, I've got the money, I want to improve my quality of life, and I went for the stair lift. But I think those of us who work in the UK setting would see that that £10,000 could have been used in a much different and in a much more better manner. But this is what we are dealing with, and until and unless as professionals we are confident of addressing these issues, our patients and carers will never be. So I think it's paramount we make these things aware, make these things known. Those days are over where we used to hush up certain things. You're not losing your memory. No, I would rather say, yes, it is possible, but there are strategies around it. Once you have the strategies, you'd be able to manage some of these problems much better. So that's my strategy.
One here, and then last one at the back.
Penny Waterson from the Motor Neurone Disease Association of New South Wales in Australia. I just was noting that you said there were 20 participants in the study.
Say that again, 20, yes. 20 participants, yes.
And then throughout the presentation you said a significant number.
Yes.
You're showing
Of the 20.
Of the 20.
Yes.
So how many of the 20 showed?
16%, 16 of them showed cognitive impairment in some or all of those domains.
And is that using Woolley's scale or
Yes.
your observation?
Both. Woolley's, carer perceptions, as well as semi-structured interviews and observations.
So using both those measures,
Yes.
a total of 16?
Yes. However, we are hoping to recruit more into the study, and obviously the final picture could be different. I know recent research literature says up to 50%, but we have certainly found higher. Now it could be, now this is a feasibility study, we did think about this, we did think about why we have such high numbers. And it could be because we are trying to get to our patients within our center to come to us for part of the study. We've been trying to propagate the message around this study. So maybe the patients who are coming to us and who we are evaluating have cognitive impairment, and that's why they want to volunteer for the study. But it could be other reasons. And again, when the study is completed, that would be an interesting thing to look at.
And our last question.
Thank you. Rebecca Axline from Houston. Excellent presentation.
Sorry, where are you from? Where are you?
Right here?
Right.
Okay. Hi. Oh,
Hi, Rebecca.
so a comment and a question. Everyone has a different treatment protocol, and
Yes.
certainly with insurance issues. I know in Houston we do a neuropsych testing, a full neuropsych testing on all our new patients, but I know that isn't always feasible. My question to you, though, is in the multidisciplinary or interdisciplinary discussion we're having this afternoon, how do you coordinate through the other members of your team that aren't occupational therapists regarding some of the questions for dementia? For example, in our center, when there's dementia of any cognitive changes of any kind, one of the things that's also important is not only educating them, supporting them, but empowering them into the strategies early on, getting them hooked into the local networking, and also for the carers to know about the legal entities. Because if they wait too long, they're going to be incapable, incompetent to do those legal paperwork. So do you utilize other resources in your treatment team to kind of deal with all those when they're out of your scope of practice?
Yes, I mean, to be honest, I think since we've embarked on this research, each and every member of the multidisciplinary team and the interdisciplinary team that we work with is more aware that these are the kind of things we need to look at. When we have our meetings and when we have our one-to-ones, we spread the message about, if you find patients who are complaining about behavioral symptoms, who are behaving oddly, or patients you find are forgetting things, not keeping up with their appointments, do flag it up to me. So, we then spread the message around, and then, today I'm getting referrals not just from specialist nurses who are, well aware of this, but from speech and language therapists, physiotherapists, people from outside, who and even carers themselves are saying, I heard about this piece of research. I wish you could see my husband because I think there's something wrong and I can't put my finger on it. So yes, I think the more we spread the message, the more it is. And when we tell them about the practical implications of what this involves, things about, like you said, important paperwork. And for us, some of the important paperwork that we do are preferred priorities of care. And, if we leave it too long, then the patients lost their speech. They can't sit up to even engage in the process. It's not a valid, well-informed decision made, and that's why we want to get in there early. So we want to see when the cognitive impairment sets in, and for patients who are impaired, we want to get in there quickly and we want to, do something about it. But that's why we felt this is a really important piece of research and we want to take it forward.
Thanks, Malabika.
Thank you.
Please join with me in thanking all our speakers this afternoon.
Thank you.